In record mode. Welcome, everybody. I'm Lisa Salberg. I'm the founder and CEO of the Hypertrophic Cardiomyopathy Association, and for today, I am your moderator, and I am happy to present another HCMA webinar. In today's webinar, we're going to be discussing genetics and HCM. We're kind of looking at this program as a genetics 101. We're getting down to basics. And hopefully over the next couple of months, we'll do some other webinars that will build on your knowledge of genetics that are going to get more in depth. So if we don't answer everything to the level of detail that you're looking for today, stay tuned for future webinars. We probably will get into some more granular data later. First, some housekeeping notes. And there we go. We need to thank our HCMA partners for making programs like this available. And today, this program is made possible through the support of Ambry Genetics. And in fact, our speaker today, Michael Osborne, is a staff member with Ambry. And he'll be answering some general genetics questions. We're not going to talk too much about the Ambry products specifically, but if you do have any questions, we'll be more than happy to forward them to the appropriate people for you. Disclaimer, and this is incredibly important for everybody to understand. In these webinar series, we're talking about medical matters related to your hypertrophic cardiomyopathy. However, these webinars are meant for informational purposes only. You should not alter your medical treatment without consulting your personal physician first. During the Q&A portion, people may ask very specific questions. We might not be able to get into your individual case per se, but we'd be happy to address those questions offline and direct you to the proper resources. Also, it is important to remember that the HCMA does not endorse any particular product or vendor or provider of medical care. And if you have any questions about our policies in this regard, I encourage you to contact the office. We're more than happy to address them. We thank you all for participating and encourage all HCM patients and those who are in families with HCM to stay informed and engaged on topics like this and others, and join us for future webinars. So now, without further ado, I am going to hand over the controls to Michael. And Michael, if you would be so kind to introduce yourself a little bit and tell us a little bit about what we're going to do here today.
Absolutely. So my name is Michael Osborne. I am a certified genetic counselor with Ambry, as Lisa mentioned. Prior to coming to Ambry, I had 3 years of clinical experience at the University of North Carolina, Chapel Hill, where I actually mostly saw patients for reproductive genetic indications. However, the past 2 years at Ambry, I've been specializing in cardiogenetics. So today, again, we're going to be doing kind of a broad genetics talk on hypertrophic cardiomyopathy. So just to give you an idea of what we're going to discuss today, first, genetics 101. So we're going to be looking at some of the genes that are associated with hypertrophic cardiomyopathy, as well as how it is inherited. And Lisa, it's not allowing me to advance the slides.
Uh-oh. Okay. Let's see what's going on. It seems like it's trying to give you connection on the wrong screen. Hold on. Let me just, sorry for the technical difficulty. While I'm working on this technical difficulty, I forgot to mention an important housekeeping point. There is a chat box feature for questions. Feel free to use the chat box feature for questions located at the bottom here, and it will give me the opportunity to see all of your questions, and we will address them at the end. Okay, so let's try it again. And let me put the, I did that. You didn't do that, right? Okay.
That was me.
Did you do that?
Uh-huh. All right.
Okay. Back to you, Michael.
Okay. So, again, this slide is just showing us what we're going to be talking about today. So we're going to be talking about who should have genetic testing, when you should have genetic testing, some frequently asked questions, and then understanding your test results, which again, when I was a clinician, that was the question that tended to come up the most, was how to interpret these genetic test results. So in looking at Genetics 101, the first thing that I want to emphasize is that almost every case of hypertrophic cardiomyopathy is genetic. So we know that even if it appears that you're the only person in the family with HCM at this time, it probably was caused by some sort of genetic reason. Uh-oh, I've lost the ability to advance again.
Okay, I see what the problem is. I have to keep my cursor on that part of the screen, so I can't look at the questions while you're advancing. Go ahead, I'm sorry. Do you have it back now?
Hypertrophic cardiomyopathy is inherited in an autosomal dominant fashion. So basically what this means is that in most families you're going to see it being passed from generation to generation. You'll sometimes see it occurring between multiple siblings, or being passed from mom and dad to their offspring. So basically when a person has hypertrophic cardiomyopathy, there's a 50% chance that their offspring will also inherit that genetic alteration. And one thing that I also want to emphasize is that the age at which an individual develops hypertrophic cardiomyopathy, as well as how quickly it progresses and how severe the disease eventually gets, that differs very dramatically between all patients with HCM, even patients within the same family. So a mother who was diagnosed at 40 years old might have a child that has the same genetic mutation but doesn't develop symptoms until they're 60. And unfortunately, there's no way for us to predict when a person is going to develop HCM and how quickly it will progress. This pie chart is showing us a breakdown of some of the most common genetic reasons for a person developing HCM, hypertrophic cardiomyopathy. At this time, more than 20 different genes have been identified and have been attributed to HCM. The two most common are MYB, a gene called MYB-PC3, and MYH7, and together those two genes account for almost half of cases of hypertrophic cardiomyopathy. There's two other genes that account for 3% each, TNNT2 and TNNI3. And then this last colored sliver here, other, that accounts for the other 20 or so genes that have been identified to date. So these can be what we call both syndromic or non-syndromic reasons for developing hypertrophic cardiomyopathy. Syndromic means that there is HCM plus other features, whereas non-syndromic indicates that it's just HCM that's going on in the family. All four of these genes that we've already discussed, MYB-PC3, MYH7, TNNT2, and TNNI3, those are non-syndromic, meaning that a patient or a family just has HCM and no other features. In this other category, there are non-syndromic and syndromic genes. So some of the syndromic reasons that an individual could develop HCM include Danon disease and Fabry disease, both of which are metabolic conditions, and the Noonan syndrome, which is another genetic condition. The largest sliver that you see here, which accounts for about 40% of all individuals with HCM, is what we consider negative or no mutation found. So when a person goes through genetic testing, even if they have a clear-cut diagnosis on echocardiogram of HCM, about 40% of the time the result will come back negative. I'll stress this many times throughout the presentation. A negative result does not mean you do not have HCM. All it means is that there is much more to learn about the genetics of HCM, and at this time we might not know the gene that is involved in your particular family's HCM. But again, negative does not change your diagnosis. So what I want to tie in here is basically showing a visual for what I've said on the two preceding slides. So your family tree that you can see on the left side, this is something in the genetics world that we also will call a pedigree. So you can see that there's circles and squares. Squares are represented by males or represent males, and circles represent females. And the different lines going across horizontally are different generations. So you can see here that this would be a wife and her husband, and then their children here, and then the grandchildren here. And anybody who is shaded in is affected with hypertrophic cardiomyopathy. And so as I mentioned, since it's autosomal dominant, you'll usually see it in multiple generations, and you'll usually see about 50% of the individuals on the family history drawing or on the pedigree being shaded in, indicating that they are affected with hypertrophic cardiomyopathy. This schematic on the right side is showing the different proteins that make up the sarcomere, or some of the heart tissue. And you'll see some of the different genes that we previously saw on that pie chart. And basically what I'm showing is that the sarcomere is a very complicated structure, and it takes the involvement of multiple different genes, and therefore their proteins, our genes encode for the proteins, any mutation in one of these genes can cause hypertrophic cardiomyopathy, since they're all so tightly integrated. The last background slide that I have on Genetics 101 is something that I think is very important, especially for individuals who have had testing many, many years ago. There's actually two different types of mutations that can lead to genetic disease. So if we think about our DNA, our DNA contains all of our genes, and you probably remember from high school biology that the DNA code is a series of letters, A, T, C, and G. So since it's a series of letters, we can think about the genetic code as almost being like a sentence. So I put a very simple sentence here that's just meant to represent, if you'll think of this as a gene, the rat and the cat ran the lab. So this would be what we consider the wild type code, meaning that there is no mutation in here. So this is the normal sequence of letters that we would expect to see for a gene. One type of mutation that can lead to disease is something that we call a sequence mutation. And so that's where one of the letters in the sequence is changed. So you can see here I've changed the D to a B. And this would be, again, similar to changing an A to a T or a T to a G in the DNA sequence. So you can see now when you read that sentence, it doesn't make as much sense as the original one did. The other class of mutation that we can see is something called a deletion and duplication. And so just like this sounds, rather than one letter being substituted or changed, there's actually an entire chunk of the sentence that is deleted or can also be duplicated. So you can see that with a deletion or duplication, the rat and the cat were in the lab now just reads the rat the lab. And so these two different types of mutations both can lead to hypertrophic cardiomyopathy. And we'll talk about why that's more important later on in the frequently asked questions section. So getting to the who, what, when, where, and why. Who should have genetic testing? Two groups of people, in my opinion, I think should consider genetic testing. And one is every person, I think, that has been diagnosed with hypertrophic cardiomyopathy should at least have a conversation about genetic testing with either a genetic counselor or with their cardiologist. Also, I think that every person that has a family member with an HCM-related mutation should consider genetic testing, or should at least have that conversation with their physician, with a primary healthcare provider. I get these recommendations from a paper that I've taken a screenshot of the title of the paper as well as the authors here. So this is a collaborative effort of the Heart Rhythm Society and the European Heart Rhythm Association, HRS and EHRA. These are cardiologists that have come together and have issued a series of guidelines for genetic testing for not just hypertrophic cardiomyopathy, but for many different types of cardiomyopathy and also arrhythmia conditions. And you'll see here that they have issued what they call a Class 1 recommendation for every patient that has been diagnosed with hypertrophic cardiomyopathy and every patient that has a family member with an HCM-related mutation. So again, there's many reasons why people do or do not proceed with genetic testing, and it's a very personal decision. We'll talk about some of the pros and cons later on in the presentation. But the Class 1 recommendation and my point in this slide is that everyone should at least have that conversation. You should at least discuss the possibility of genetic testing with your doctor, with your family members. There are rare instances where genetic testing will not be informative, such as if you're a 70-year-old individual who was just diagnosed with HCM, you have no siblings, your parents are no longer alive, no children, then for you, genetic testing is probably not very informative. But for the vast majority of individuals with a diagnosis of hypertrophic cardiomyopathy, it is certainly worth the discussion. When should you have genetic testing? Well, there's no right or wrong answer to this. Every situation and family structure is unique. However, I think it's at least worthwhile to establish a timeline. So when should you at least begin to start thinking about the pros and cons of genetic testing? And I think that's as soon as you're diagnosed with HCM. So if you're the very first person in the family diagnosed with HCM, or even if you're not the first person in the family diagnosed with HCM, that's when you should start weighing some of the pros and cons of genetic testing. Also, if you're not affected with hypertrophic cardiomyopathy, but one of your family members tests positive for a mutation in one of those genes, I think it's worthwhile for you to start considering genetic testing to start weighing those pros and cons. And then I also put here if a family member is diagnosed with HCM. So the asterisk implies that you have a family member diagnosed with HCM, but they might not have proceeded with genetic testing yet. One of the intricacies of genetic testing is that it is always the most informative for an affected individual to proceed with genetic testing first. So if I found out that my mother was diagnosed with HCM and I went and had an echocardiogram, did not have any features, the genetic testing for me is probably not going to be helpful. What's going to be helpful is for my mother who is affected to have genetic testing first. And then if she tests positive, if we find her mutation, then I can test myself for that same mutation. Recall from the pie chart that about 40% of the time, the results come back with no mutation identified. So if we don't identify a mutation in an affected individual in the family, we're certainly not going to identify it in an unaffected person in the family. So that's why it makes sense to test an affected individual first. So some of the pros and cons of genetic testing. I'll start with listing out the pros. Certainly, the genetic testing can confirm the diagnosis. Now, for most of you, you'll be diagnosed by an echocardiogram, and it's likely a slam dunk diagnosis. However, one thing to think about is that, as I already mentioned in the previous slide, in rare instances, there are syndromic and non-syndromic cases of HCM. So for a rare subset of individuals, a rare group of individuals with what appears to be just hypertrophic cardiomyopathy, they'll proceed with genetic testing and find out that they actually have an underlying metabolic condition, such as Fabry or Danon disease. And certainly when you have a syndromic reason for HCM, the screening, management, medical interventions, all of that is very different. I already alluded to this. It may change the medical management for some individuals. And it allows for what we call cascade testing of family members. So again, if I am diagnosed with hypertrophic cardiomyopathy, I proceed with genetic testing and we find a mutation in MYH7. What that allows is it allows all of my children, all of my siblings, my mom and dad, it allows everybody and all of my first-degree relatives and beyond to go in and have a simple test for that one mutation. So rather than testing for all of the mutations and all of the genes, they just have to test for the one that was found in me, and it's a definitive yes or no. Yes, they have the mutation, and they're likely to develop hypertrophic cardiomyopathy at some point in their lifetime, and therefore should be screened appropriately. Or no, they don't have the genetic mutation that was found in me, and therefore they're off the hook. We'll talk about that in a little bit more detail. And by allowing some of those individuals to test negative, there's a cost savings. So as you know, right now the recommendations for clinical screening, such as echocardiograms, they suggest having repeat echocardiograms every couple of years for your entire life, since you can never predict when or how severe you will develop HCM. If a person tests negative for the family mutation, then they never have to go through that clinical screening again. So some of the cons, when I talk to patients, they do discuss possible feelings of guilt. So, gosh, I can't believe that I've already had children and I could have passed this on to them. Of course, there's absolutely nothing that a family could have done to prevent it being passed on when they did not know that they carried a mutation, but that is one of the things that comes up during a clinical session. there is the possibility of an uncertain result. So genetic testing is not cut and dry. It's not always positive or even negative. There are sometimes results that come back inconclusive, which I'll talk about more in a moment. And then many patients have fear of insurance discrimination. Now, for a patient who already has a diagnosis of hypertrophic cardiomyopathy, so if you've already had an echo and been diagnosed with it, it's in your medical record. So genetic testing probably isn't going to complicate that further. But if I have a sibling that was diagnosed with hypertrophic cardiomyopathy and I myself have not been diagnosed yet, the fear of insurance discrimination is something I should consider before proceeding with genetic testing. So this brings me to a very important slide which discusses a law called GINA. It stands for the Genetic Information Non-Discrimination Act. And so this slide is highlighting that the Genetic Information Non-Discrimination Act, it does protect individuals against discrimination in access to health insurance. It protects against discrimination from the use of your genetic test results in matters of employment. And it protects against discrimination from having your health insurance canceled, rated, or withdrawn based on your genetic test results. So again, if I did not have clinical features of HCM at this time and I decided to proceed with genetic testing to find out if I was predisposed, GINA protects me from all of these things. However, GINA does not protect from everything. It does not protect from life insurance companies using this information to rate your policy, nor does it protect from long-term disability. So again, if I was an unaffected individual that found out I was at a 50% chance of having the same mutation, prior to proceeding with testing, this goes back to the when should you proceed with genetic testing, prior to proceeding with testing, I would certainly recommend getting your life insurance, if you're interested in life insurance, getting that policy established and getting your long-term disability.
Oh no. We have stopped recording for some reason. And I really want to be recording. So now we're back recording. I'm going to have to edit them together. I'm sorry. Proceed.
No worries. All I was saying is that if I was an individual who was not currently affected with HCM, but I knew I was at a 50% risk, I would want to go out and apply for my life insurance policy and my long-term disability insurance prior to proceeding with genetic testing. Again, GINA is a great resource, and I'm very glad that we have it to prevent against discrimination from health insurance and employment. However, it does not cover everything. There are a couple of additional caveats with GINA. It does not apply to members of the military, and in certain cases, there are limitations in terms of employment if it's a very small business. So I would recommend talking to a genetic counselor, to your physician, if you do work for a smaller company or a member of the military, or if you are a member of the military, about GINA.
The other piece I will add to this, I think there's one more line on that particular slide. You can actually be denied a life insurance or short-term disability policy. It's not just a rating issue. You could actually be told, no, we're not going to insure you. So you would want to know that before you went ahead to do the genetic testing.
Mm-hmm. And Lisa, if you could, I think it's letting me advance again.
Yeah, when the recording stopped, it did that. Okay. Sorry about that.
It's all right. It looks like it's letting me go through again, so we should be good to go. Okay, so now I want to talk about possible ways that your genetic test results will come back. So as I mentioned, genetic testing is not cut and dry, and this is the question that I probably get the most as a clinician is, what do my results mean? So there's three general possibilities for how your genetic test results will come back. Of course, positive, a variant of unknown significance, and then negative or no mutation found. And we'll talk about each of these in more detail now. So a positive result, it means we found the genetic reason for hypertrophic cardiomyopathy in you, the patient, and or your family. What this means is that cascade testing is now available for family members. So as I mentioned, now all of my first, second, third degree relatives are are able to go out and have very informative genetic testing. They're able to go be tested for that exact same mutation that was identified in me, and then find out if they are going to develop HCM at some point in their lifetime. Now, there's another way to think about positive results as well. So in this instance, I'm implying a positive, I'm implying a positive result as a patient that's already been diagnosed with hypertrophic cardiomyopathy. Another way to think about a positive result is I'm currently unaffected and I've gone through with the family testing and I found out that I carry the same mutation. In those cases, it isn't just that we found the genetic reason for HCM, it's that you should also go establish yourself with a cardiologist immediately. Go get a baseline echocardiogram and talk about what your lifetime screening should look like. Genetic testing, a positive result will reveal whether hypertrophic cardiomyopathy is non-syndromic or syndromic. And as I mentioned, especially if it is syndromic, like a metabolic condition, it may change medical management. Now, a variant of unknown significance. This is probably the most frustrating result that comes back as a clinician. So this means that we found a difference in your DNA, but we have no idea what it means. We don't know if it is some sort of change that just makes me, me, and you, or if it's something that is actually contributing to your disease. In this case, a variant of unknown significance does not change your diagnosis of HCM. You still have hypertrophic cardiomyopathy. It still is probably genetic, and your first-degree relatives are still at 50% risk of having the same condition. However, for a variant of unknown significance, the cascade testing is usually not recommended. We don't want to test family members for a result that we don't understand. There have been previous cases where family members were tested for a variant of unknown significance, and they were negative, meaning they didn't identify the VUS, so they did not proceed with screening. And then many years down the line, we found out that that VUS, that variant, was actually not what was contributing to disease, and therefore they were at risk the entire time. They had false reassurance. So we would not recommend doing genetic testing for a VUS, for a variant of unknown significance. Clinical screening, such as those echocardiograms, that's still recommended for the patient and all first-degree relatives. So that echocardiograms, the clinical screening does not change. It is possible that the laboratory will reach out to you and the clinician to offer follow-up studies. So there's something called family studies, which is where we can take other members of your family, family, and we can actually look for that same variant, that same difference in the DNA in your other relatives on a research basis. And if we see it tracking in the family history, as we would expect, then it can lend additional evidence that allows us to reclassify. So just because you get a variant of unknown significance doesn't mean that the genetic testing route stops there. Trust that most laboratories continually look in their databases and update these variants based on any additional evidence that comes out. And for most laboratories, if we are ever able to update the variant that was seen in your family, we'll issue an amended report. And then finally, we have a negative, which means no mutation found. So there's two slides on a negative result, and I'm going to start with what we call the index patient. So let's pretend that I'm the first person in my family diagnosed with hypertrophic cardiomyopathy, or even the fifth person, but I'm the first person to go through with genetic testing. So a negative result, no mutation found, that means that we did not find the genetic reason for HCM in me, the patient, or that was likely in my family members. And again, I want to stress, this does not change your diagnosis of hypertrophic cardiomyopathy. What that indicates to us is that the 40% of individuals that still get a negative result probably have mutations in other parts of the genes we already know about, or in a completely different gene that we haven't discovered yet. So there's more to learn about this condition. On the clinical level, it does not change your diagnosis of hypertrophic cardiomyopathy. As with a variant of unknown significance, cascade testing for family members is not available, so there's nothing to test for in your family members. If we don't find it in an affected individual, we're not going to find it in an unaffected individual. As with a variant of uncertain significance, clinical screening such as those echocardiograms is still recommended for the patient and for all first-degree relatives. And you can consider repeating your genetic testing at a later date. Again, I would not recommend doing it 3 months later, but if it's been 5 years, 10 years, and a whole handful of additional genetic tests have been added or have been discovered, then it might be worthwhile to think about repeating genetic testing. Now, a negative result in family members, we've already alluded to this, so let's pretend that my mother has hypertrophic cardiomyopathy. She proceeded with genetic testing, and my mom found they found a mutation in my mother. So then I proceed with genetic testing, and I test negative. So that's what I mean by negative in family members. This means that we did not find the genetic reason for HCM that was previously seen in my relative. So we did not find the alteration that my mother had that caused her to develop HCM. And what this means is that I do not have genetic hypertrophic cardiomyopathy, and that it is incredibly unlikely that I will develop hypertrophic cardiomyopathy. I should never put never. You will not develop HCM. There are acquired versions as well. But my risk is the same as anybody else's risk in the general population. It's no higher, and I do not need the additional screening or follow-up or echocardiograms that I would have needed based on family history alone. Also, if I decided to have children, my children do not need to have genetic testing. I don't have a mutation, and you can't pass on what you can't have. So it essentially, for my branch of the family tree, it stops. And if you test negative for a known mutation in the family, that testing does not need to be repeated ever. It's one and done.
I do want to pause for 1 second here with just a cautionary tale, if you will. So it's exceedingly rare, and I'm asked this question probably once or twice a month. If my family member was screened clear, there was no mutation found, is that 100% sure that there's nothing there? We don't know every single mutation that causes HCM. Remember that, almost 50%, that we don't know why they have HCM. We can't find the mutation yet because we don't know enough yet. There is a small chance that somebody has a mutation that we haven't discovered yet. So while all of what Michael said I completely agree with, one should be constantly vigilant that if there are symptoms that show up or something's not quite right, at that point we might have to go back to the sandbox and try again and revisit this. If we look back to the mutations that were identified 15 years ago and you look what we have today, there's not a big change, but there's little changes. And if one of those little changes happens to be in your family, it might become relevant in the future. So it's not 100%, it's in the high 90s, I would say, but nobody really knows yet. So you can take a lot of faith from a negative genetic test in terms of if I don't have that mutation, it's probably not there. But there could be a secondary mutation or something else going on. So we just need to have a little bit of vigilance there.
Right. And
back to you, Michael.
If you test negative, again, your risk is not zero. Nobody's risk is zero, even without a family history. It goes back down to the baseline, the population risk. So if you test negative, you don't need to do the additional screenings, the echocardiograms that somebody in the general population would not be proceeding with. But as Lisa mentioned, if something suspicious pops up where you start having fainting episodes or clinical symptomology of hypertrophic cardiomyopathy, then don't ignore it. Don't ignore it. All right, so the last couple of slides, these are just some frequently asked questions that come up that Lisa receives and that I would have received in the clinic. So number one, will my gene tell me how my hypertrophic cardiomyopathy will or will not progress? And the answer in most cases is no. As I already mentioned, mutations, or different cases of hypertrophic cardiomyopathy, even within the same family, people can have different ages of onset. So one person can be diagnosed at 20 and another person might not be diagnosed until they're 50. Some people might have a very, very slow progression. In rare instances, it might become so severe that cardiac transplantation is required. And again, that's rare, but that just goes to show you how, the variability in the disease. And unfortunately, genetic testing in most cases does not inform how quickly your disease will progress, if at all, or when you will develop symptoms. The only reason it can provide information is if you're in the rare subset of individuals that have a metabolic condition. But again, that only accounts for a couple percentage of individuals. So more than likely, the answer to question 1 is no. Question number 2, how often should I repeat genetic testing if no mutation is found at my original screening? And I would say that this depends on how quickly research is able to contribute to the discovery of new genes. I think every year or every couple of years it is worth having a consultation with your cardiologist or a genetic counselor to see if any additional genes have been discovered, especially genes that account for an additional 5–10% of previously negative or no mutation found patients. If you've already had genetic testing, one thing that I would recommend having your physician look or the genetic counselor look for on the report is to look and see, number 1, the number of genes that were included. Was it just 2 genes? Was it 25 genes? And also to look and see if they were looking for the 2 different classes of mutations that we discussed. Remember, there's sequencing alterations, the changes in the letters, and then there's deletions, duplications, where whole chunks of the sentence or of the gene are missing. And up until recently, most laboratories were only doing this, were only testing for sequence alterations, and were not including for deletion, we're not testing for deletions or duplications. So it's worthwhile to go back and look at the report and see if deletion duplication testing was performed. Number 3, should I screen my newborn child? Ooh, this one's tricky. The question, the answer to that question is very family specific. If there is hypertrophic cardiomyopathy in the family, the most common age of onset is in the 30 to 40 range, right? So most of the time, young children are not going to be at risk. However, there have been young children reported in the literature that develop hypertrophic cardiomyopathy when they are still children. That is rare, but for that reason, I would, again, at least recommend having a conversation with the physician about the possibility of testing the child. If you're not comfortable with genetic testing, then I would at least recommend having the child screened by a cardiologist, because again, rarely the hypertrophic cardiomyopathy can develop in children.
I will pause there to mention the life insurance issue. Obviously, we don't want to think of our newborn children needing life insurance. However, most insurance companies will not insure a newborn until they're over a certain age. Some are 30, 60, 90 days old. So you can't even put them immediately on a family life insurance policy. And that genetic test result is going to stay with them through life. It would be my ultimate goal to see Gina include life insurance and long-term disability insurance, but I'm a realist and I'm not holding my breath for that. So you need to consider that newborn child is someday going to have a family of their own that they may want to protect. So you may want to give that some consideration before screening.
Mm-hmm. Absolutely.
Next.
Number 4, what does it mean if I have a double or triple mutation, and how common is this? So recall that, actually I didn't talk about this, but everybody has 2 copies of every gene. We get 1 copy of the gene from our mom and 1 copy from our dad. And so we all have 2 copies of MYH7. We all have 2 copies of MYBPC3. And so in some patients, they have a mutation not just in 1 copy of MYH7, but in both copies. They've inherited 1 mutation from mom and 1 mutation from dad. That is rare. The literature right now suggests that accounts for about 5% of overall patients. I think that's an overestimate. I think it's actually probably a little bit less than that. But it does happen where patients have more than one mutation. Generally, in these families or in these individuals that have more than one mutation, they develop features of hypertrophic cardiomyopathy much sooner, much earlier. So those would be the individuals that you would see developing features in childhood or in their teenage years, and the progression tends to be much more severe. So again, it does happen, and it does have clinical implications, but it's rare. Again, the literature, I would go with about the 5% number, because that's what's in the literature right now, but I suspect that number will change as we get more data. And then finally, how do I encourage my family members to get screened? This is a tough one as well. If you have a close relationship with your family, then I would certainly recommend sitting down and chatting with them. But that's a perfect world, right? And so there can be family members that you haven't seen since since in 10 years at the last family reunion, or that live in other countries, or on other sides of even this country. And so one of the ways that we're taught in school to encourage family members to get screened is something called a family letter, and it's just like what it sounds. The letter would be written by your provider or by a clinician in a simplified manner, but addressed to your family member and from you. And it's basically explaining what hypertrophic cardiomyopathy is, what the genetic test result that was found in you, what that means, how you can be tested for it, or how they can be tested for it, your family member can be tested for it, and then also the clinical, the screening recommendations, not just genetic screening, but also the recommendation for echocardiograms. Most genetic counselors have a template letter that they're very happy to provide and even send out for your family members on your behalf. Many laboratories, including my own, have family members have the family member letters on the website available that you can download and print off and mail to those relatives. Oftentimes, these letters will also include a link to the National Society of Genetic Counselors, so that they can even find out where the closest cardiovascular genetic counselor in their region is located. So ideally, it would be a conversation to have in person or over the phone. If that is not possible because of family dynamics or because of distance, then I think the family letter is the next best route.
In addition, on that issue, we can be of assistance as well if the family doesn't understand what HCM is in general. We have a packet of information that we would be more than happy to send to your family members or give to you in downloadable format so that you can email and communicate with your family members via email as to what HCM is and why it is important that they find out sooner than later whether or not they're at risk. A lot of times we'll hear from family members saying, why do I need to know if I'm going to die? I'm going to die, and they're going to be very, dramatic about this. But we know the reality that most people with HCM live to or surpass the average age of mortality, and we want to make sure that they get there as healthy as possible. And we want to help them avoid the unnecessary negative consequences of not being diagnosed. So if there's anything that the HCMA can do to help you educate your family, you are the big-hearted family member. You are the one who is getting educated, and we are here to help you help them. So please use us as a resource there. Back to you, Michael.
All right. And then the very last slide, and these were put together by Lisa, so some of the concerns that have come up for the association members. Why get screened if it will not tell me how HCM will progress? So there's a couple of reasons. Again, number one is in rare instances, the cardiomyopathy that is seen in your family might actually be syndromic. So there might be additional things to think about. That is incredibly rare. I'm not trying to cause panic among the masses, but that is one reason to think about genetic testing, is it can rule out those other metabolic conditions and let you know that there's no other body systems you need to be thinking about. Also, the cascade testing. Without genetic testing, all first-degree relatives of an affected individual, it's recommended that they go through with repeated echocardiograms and consultations by a cardiologist throughout their lifetime. And the only way to proceed with that genetic testing that lets people off the hook is, of course, by doing genetic testing in the affected individual first. So that's another reason to think about, even if it might not change things for you, even if it just confirms what you already know and you find out that you have a mutation in a gene associated with non-syndromic HCM, it still makes a big difference for family members.
I'm going to pause on that one and give a futuristic, optimistic view.
Mm-hmm.
There may come a time in the very near future where your genetic mutation will indicate what medications or what treatment pathway may be good for you. And I can't say that it's, something that's coming next year, although it might be. There are a few new drugs being tested, and some of those drugs are being looked at very specifically to which mutations they seem to be more effective in. So it may, at some point, change your management. Absolutely. Beyond the syndromic versus non-syndromic. It may play a better role or a bigger role later, even so much as a deletion versus another type of mutation might respond differently. So the more detail we can get, it might help you later. So keep that in the back of your mind.
Absolutely, and I've seen this in many other genetic condition types, so seizures and epilepsy, cystic fibrosis being other examples, where the families that had already proceeded with genetic testing are the first ones eligible for clinical trials for new medications, and insurance companies are starting to catch on, and especially if new drugs have particular genetic targets, those insurance companies are not going to approve it without proof of genetic testing. I can guarantee that. And so, again, those families or those individuals that have already proceeded with genetic testing are the first ones that are able to get whatever new drug treatment comes down the pike.
Michael, question I didn't put here, and I'm sure a lot of people will have. What is the time frame for genetic testing? If I went to the doctor today and they drew my blood, how long is it going to be until I get an answer?
It could be up to about 4 to 5 weeks. So it can come back a little bit faster, but I think you can expect to have results within a month, month and a half. Again, depending on the laboratory. That's what it is for Ambry, so I can't speak for other labs. But previously, several years ago, it could be months and years, and now we're able to do all of those genes at once, as opposed to just one at a time in a matter of weeks.
Yeah, I waited 6 years for my results because I was in the early days. Next question, what if my family gets angry with me for asking them to get screened?
That might happen, and again, that goes back to the different dynamics between family members. My approach is I think we all have our due diligence to at least notify family members, and then depending on the relationship you have with them, you know how you can push buttons of family members. Some you just leave alone, and some you can be a little bit more pushy with. Again, it is possible that a family member will get angry, but I think for most patients, for most family members, I think eventually they come around and are appreciative of the information. Regardless of whether or not you disclose the genetic information, it doesn't change the fact that they're at risk for hypertrophic cardiomyopathy. So genetic results are not, this is a genetic condition, and they are at risk. And so I think that's one way to look at it. Again, regardless of genetic testing, it's still hereditary.
Should I tell my child's school about his or her mutation?
So again, another very tricky one. Lisa shared with me a story yesterday about a private school denying admission to a child who had a mutation, and that is allowed, apparently.
Strangely.
So for public schools cannot, of course, deny admission for an individual, for a child that has any sort of genetic condition. They have a legal, or any condition really, they have a legal obligation to tailor their education and support resources for every student at that school. Private schools do not. So that is something to think about. Again, there's certainly pros and cons. My gut tells me that it's worthwhile to share the family history, to share the genetic mutation with the principal, with the teachers that are going to interact with that student, so that they're prepared in the unlikely event that something happens. again, children that have a mutation, it is unlikely that anything will happen while they're children, but that risk is not zero. And whether or not you disclose the information, it doesn't modify the risk or the likelihood that something could happen at schools. So my advice would be to at least consider sharing that with the school, with the principal, with the teachers, so that they are prepared in the unlikely event something happens. But again, just be aware of the cautionary tale that private schools can deny admission.
I was very shocked to hear that one and find that there was really no recourse that we had to fight with them. I just thought it was a terrible school. I was kind of hoping we'd make a little bit bigger deal of it to say, what an awful school. Don't send your kids here. But it is what it is. Okay, we have some questions that we're going to address now. I took the controls back there, Michael.
Okay.
I think we've answered some of these as we went along, but I'm going to read them off.
Okay.
What is the point of typically recommending to test a baby of a gene-positive mother? Well, to see if the baby has the gene or not. And when you do that, again, we discussed, should I test the newborn? You really need to think as a family, when does this affect the individual mother of that child? Did it show up as a teenager or in their 20s or 30s? Or was that mother an infant with HCM herself at one point, at which point you'd want to be a little bit more aggressive? But you can probably do that with an echo and a proper workup from a cardiologist. So when the gene test is questionable. Will you get a copy of these slides after the presentation? Well, yes. It'll be up on YouTube. However, we did have a little glitch in the middle where, for some reason, out of nowhere, it just stopped recording, and then I started again. So I have to figure out how to meld those two together, and that might take me another day or two. So you'll have it by Monday, hopefully. Every person who has a family member with HCM-related mutation. Question, a proven mutation or just a diagnosis? So I think what, Bob, you're talking about there is we talked about who should get genetically tested. And every person with an HCM-related mutation, what we're talking about there is I'm the person with HCM. My daughter might be affected, hypothetically, so she should get screened because I know my mutation. And that's who we're talking about should be screened. If I'm the index person and I don't know my mutation, then there's no use in testing the other family members.
That's
Michael,
right.
jump in if I need to be clarified.
Nope, that's correct. So when we're talking about screening relatives, there's two different ways you can think about screening. There's clinical screening, and then there's genetic screening. So clinical screening means that all first-degree relatives of a person with HCM should be meeting with a cardiologist and should be going forward with their repeated echocardiograms. Genetic screening is where you're actually doing genetic testing. And so you would not want to proceed with genetic screening unless, number one, somebody in your family had already had it and tested positive, or unless you yourself had already been diagnosed with HCM by an echocardiogram. If you just had a family history of hypertrophic cardiomyopathy, but you yourself had not been diagnosed yet, then genetic screening is not recommended yet. We like to test an affected person first. If there is no one in the family to test except you, then of course we can proceed. That's a whole different conversation to have. But if at all possible, it is best to test an affected person first.
All right, this is a complicated question and a good one. Can you be a carrier of an HCM gene without ever developing symptoms and still spread it up to your offspring? And I will add something to your question, Laura. And can my offspring have a different presentation than me?
The answer to both of those is yes. So yes, you can be technically a carrier of a genetic mutation and not develop symptoms until much, much later. Essentially, if a person lives long enough, and we think that HCM is, so what I mean by that is, assuming you're not crossing the street and hit by a car when you're 20 years old. So if a person lives long enough, then every person with an HCM mutation almost every person will more than likely develop HCM. As we've already discussed, though, it's very difficult to say when that person will develop HCM and what their course will look like. So yes, it is possible that a 75-year-old individual could appear to be a carrier of an HCM mutation that was found in a relative and not develop symptoms, not have developed symptoms yet, but more than likely they will. And it is possible that their children, there's a 50% chance that each of their children will carry the same mutation, and that it could appear earlier, that the presentation of HCM could be different in the offspring.
Next question, complicated, and I'm going to dive in here a little bit. What is the correlation between the mutation in HCM genes and the intraventricular septum engrossment, he worded it as? So the first thing I want to say here is where your hypertrophy is located is not something you should be focusing on. Whether you have apical HCM, the septum is thick, the free wall is thick, it's all the same mutations. So whether it's septal or apical or free wall, don't think about it as where is the hypertrophy. That's why HCM has 75 different names, because every time somebody found hypertrophy in a different location of the heart, they renamed the disease, which confused everybody for a really long time. So don't think about it as where is my hypertrophy. Now, mutation versus area of hypertrophy, to my knowledge, at this date in 2016, there is no correlation between the gene mutation and the area of hypertrophy. It just is what it is, and we don't understand it yet, which is why we all need to group together as a community and try to answer these questions. Michael, any additions?
No, I agree with that. As Lisa mentioned, there's a ton of different ways that you can refer to hypertrophic cardiomyopathy. I hear obstructive the most when I'm out talking to different cardiologists. It's all the same genes. So where the hypertrophic cardiomyopathy appears to develop and how quickly it appears to progress, whether it becomes obstructive or not, it doesn't appear, at least at this point, to have a correlation with the underlying genetic mechanism or gene.
Okay, next question is multifaceted, and it's Jeff. He had genetic testing 6 years ago with negative results or no mutation found. When should I have another one? My recommendation there is go back, look at the lab report that you had done, see what mutations were covered in that lab report of 6 years ago. If there are new mutations on new panels from other companies, I would call them and say, hey, can we test for these because I already tested negative for those, and we can work it out that way. I don't think you really need to go through a full panel again, and thereby you might be able to get a cut in cost into how you're going to do this, so talk to the testing companies. 6 years ago to now, probably not a lot of new data, so I wouldn't necessarily think you have to redo the whole thing at this point. So I would talk to your physician, I would talk to the testing companies, and go forward there. We have 3 children who have tested negative on echo. How often should they be tested? Children between the ages of approximately 11, 12, and about early 20s should be screened every 12 to 18 months by an echo, EKG, and a checkup with a knowledgeable cardiologist in HCM. And then adults should be tested every 3 to 5 years throughout life. And that is, again, echo, EKG, and checkup with a knowledgeable cardiologist. They're not all as knowledgeable. Michael, any additions on that one?
That's correct.
I believe...
Just going back to the when to repeat testing if you had a no mutation found. Remember that in addition to the gene content, so which genes were included, it's also important to look at what technologies were done. So there's the sequencing alterations and there's the deletion duplications. And so those reports can get very wordy and very technical. So I would make a note, sequencing and deletion duplication, and then you can ask the genetic counselor or the physician to check and make sure that both types of mutations were done. If they were not, if deletion duplication was not performed, even if there's no new genes on it, it might be worthwhile to
redo it, yeah. Thanks for the clarification. That's an excellent point.
Because
number one, I want to be cognizant of our time. We have hit an hour. I didn't expect to do that, but you've got some awesome questions here. So I'm going to keep going on the questions, and We have had 50 some odd people stick with us the entire webinar, so stick with us a few more minutes. I think you'll like the other questions. There's a good one coming up. Okay, next question. I believe double or triple mutations in this case are actually referred to as 2 or 3 mutations in different kinds and not homozygous mutations. Michael, hit this one.
Yeah, so that's tricky. There can be, when we say 2 or 3 mutations, they can be mutations in both copies of the same gene. So you could have a mutation in both copies of MYH7. It could be that you have 1 mutation in MYH7 and 1 mutation in MYBPC3. There's also something incredibly tricky, and it just boils down to terminology, where you could have mutations, 2 mutations in both copies of your MYH7 gene, for example, but we don't call them homozygous, we call them compound heterozygotes, because even though they're in the same gene, the mutation itself is different. So one might be a sequencing that we've talked about, the other might be a deletion duplication. So I didn't really delineate in that slide what type of mutation or where those 2 hits might have occurred, or even triple hits might have occurred, but you're exactly right. It can be 1 in one gene, 1 in the other. It can be both in the same gene, and even within the same gene, the mutations could be the same or they could be different.
Simply put, not a really easy answer, and remember, this is the 101 course. That's like the 405 course, because that's getting complicated. All right, the next question is something that I'm asked often, and while there are some tricky ways of getting through this, it's a little complicated. Well, something like 23andMe, so the type of mutation that medical genetic testing would. It's obviously cost-effective at $200 out of pocket, but will it give you data? My quick answer is not really. However, I have somebody who got really tricky. Mom got me genetically tested through a high-level genetic testing company, but then Mom went and did 23andMe, and Mom is really smart, and Mom napped her SNP and then tested her kids that way. I don't recommend it at all. It's complicated, and it could be incredibly misleading, and you're not getting the same quality of reports. But, yeah, no. And you really need to stop and ask yourself, if you're doing that type of genetic testing, a really important question. Where the hell is your data going? Mm-hmm. And if you don't know the answer to that question, you should be asking those questions.
Right, and let me take off my Ambry industry hat and put on my clinician hat. I would not recommend doing 23andMe or any other direct-to-consumer genetic test, especially one that is claiming to provide medical results. Now, there's some fun ones out there, like where you can get, a picture of your chromosomes, or where you can find out your ancestry, and that's fine if you want to do it. But any time that you're looking for a medical diagnosis, I would recommend finding a lab that is what we call both CLIA and CAP certified, and also that requires a physician signature. A lot of labs are. Not all genetic tests are created equal, so it would be a simple. Essentially, it's like if you're looking for a form of transportation, and yeah, you could go down the street and get a car for $99, but you might get a quarter of a mile before it blows up. Or you can go to Honda or Toyota or a more reputable dealership and get a newer car, pay a little bit more, but it's going to be reliable and it's going to be safe. And that's the same way to think about genetic testing. Just because a lab says they're testing for cardiomyopathies doesn't mean they actually are, or doesn't mean that they're doing a thorough analysis, or that they're providing quality information or a result that you can report, or that you can interpret rather. So please be aware of that. Most of the time with genetic testing, if it says it's a $200 out of pocket, or if it seems too good to be true, most cases it is. I will also say that the price of genetic testing in general, even for clinical laboratories, has come down dramatically. It used to be tens of thousands of dollars. Now you can get a full panel of all of these genes that include sequencing and deletion duplication for a few thousand. Insurance is starting to understand the importance of it as well, and most laboratories, including Ambry, will actually do the benefits check for you. So you'll find out before testing is performed what your out-of-pocket will be after insurance kicks in. So
I'm going to try to cruise through these questions pretty quickly here because we are getting short on time. Somebody asked, so if I had genetic testing 3 years ago, is it not in-depth enough by today's standards? It probably is in-depth enough. You just want to go back and you want to know your lab. And for most tests that we have today, you get a blood work done or a biopsy done. You're not really stopping to ask who did the pathology on it, where did my blood work get done, what protocols did they use. But within hypertrophic cardiomyopathy and genetic testing as a whole, you want to know what lab. You want to know what it included. And even if you had it done 3, 4, 5 years ago, you can call them back and say, I had my testing 5 years ago. What were you looking for then and what are you looking for now? Is there really any difference? The companies that are listed on the HCMA website as genetic testing companies are all pretty much using good technology. We've talked to them. They're all a little bit different. They all have their attractive differences, but they're all solid companies. And you really need to look at who did your test, when they did their test, and ask the questions of the genetic counselor on the phone or within your HCM Center of Excellence. There appears to be several types of tests that can be done. What should you ask for specifically? Go to the HCMA website, look at the companies that we've listed there. If your doctor is using somebody other than them to do the genetic testing, you want to ask, what lab are you using and why aren't you using one of these? Sometimes they'll do in-house genetic testing. They have a lab themselves that they're doing it on. And it's a CLIA-approved lab, but it's a proprietary lab to that institution, medical center, or university. So you just want to ask the questions. It may not be a bad lab. It just may be a private lab. And there's a couple other ones that are not on our site because they're predominantly research-focused. Mm-hmm. So if you're going to be getting your testing done through this research lab, doesn't mean it's lesser quality than the commercial labs. It's just they have a different structure of running their business. Cost range, $2,500 to $3,500, generally speaking, is a good place. I have been beating them up on your behalf for a number of years. When we started, it was about $8,000, and it's come down. And the out-of-pocket has been made a lot more affordable for most people because they'll do copay deductible, they'll work with you on all of that. So talk to them. If you're not sure if you can afford it, call them up. They'll run it through your insurance company. They'll see what your out-of-pocket's going to be. They'll work with you. Call them. Is it possible that HCM can only affect females in a family?
Ooh, good question. So most of the time it is completely random. So keep in mind there's a 50-50 chance of passing it on, just like there's a 50-50 chance of having a boy or a girl when you get pregnant. So it could just be luck of the draw. I know my mom was one of 4 sisters, which is statistically improbable, and it could also, statistics could play out in your family as well, where only females are inheriting the gene. Most of the time, though, it's going to be something of luck. There are some, again, rare conditions that are inherited in a slightly different manner than the autosomal dominant, where females can be carriers and have more severely affected males, and the females maybe only develop cardiomyopathy. Again, that's genetics like 705 as opposed to 405 or 101. The easy answer is that in most families, if it's autosomal dominant, as would be confirmed by genetic testing, it's incredibly, if it's only tracking with females, it's by chance.
So a number of the following questions are about payment. Will insurance pay or not? We have found that over the past 3 or 4 years, it went from 50-50 to more like 80-20 that they will pay, but there are still some insurance companies that will give you a hard time. For members of the HCMA, we will actually assist you in writing very complex, very long appeal letters. And we don't write a general appeal letter. We make it very specific to the individual case and explain to the person who's reviewing your case why it's important for you. Not generally why is it important, but why is it important to this individual case. Not only what about your clinical presentation, but the number of family members that can be assisted. Remember, the people that are reviewing your cases, they have families too. Mm-hmm. So if we get them to see the bigger picture, sometimes they're like, oh, all right, I'll do it. And the other thing that they'll do is they'll look at the very large stack of paper that I send them, and they don't want to read it. So they just say yes. So we take for what we can. And we're successful on genetic testing appeals about 90% of the time. We still have a few that won't do it no matter what because they don't want to open the door at all. But generally speaking, they will do it.
And if I could add one to that, please, because I think this is very important. Again, I have to put my industry hat back on now, and I can only speak on behalf of Ambry. I know a lot of other labs, as in addition to doing the insurance check for you, so in otherwise we have a separate billing department that puts together all of the information that determines what your out-of-pocket is going to be, whether it's covered or not. Lisa just mentioned the HCM Foundation will help with appeal letters. Our internal team will as well. We have many on our website. And I would say that just across all testing specialties, about 75 to 80% of the appeals are overturned. It's probably more for HCM, as you mentioned, because those appeal letters are more personalized. For those rare individuals where it is not approved or where the out-of-pocket is incredibly high, most laboratories, including Ambry, do have a financial assistance program as well, where we can, and it's based on finances and need and that kind of thing, but it's a very easy application and will assess income and can provide reduced testing. So please don't write it off from the beginning. It is, many laboratories do have ways to still get genetic testing to you.
The other thing I'll add at the very end of this long webinar is the HCMA does have relationships with multiple genetic testing laboratories. We do have a set number of pro bono genetic tests that we can distribute per year. We normally keep them for post-mortem cases. Somebody has died from HCM, and there are family members that could benefit from the knowledge of their genetic mutation. Health insurance will not cover a test on a deceased party. So we kind of save those tests for the deceased persons. However, in some circumstances, we have been able to use those tests for living persons who have just had really a difficult time with their health insurance. And not only will it help them, but there are other family members that will benefit from the knowledge of the genetic test results. So if you're an individual person, you're the only one in the family, there's nobody else that could be helped, we're not likely to give that as a pro bono test. But if you have a number of children who are willing to get tested or family members who are willing to get tested if the results come back, then by all means, we can talk about applying. And it is an application process, and we cannot accept everyone because there's just not that many resources. And on that note, I'm going to end this webinar, and I'm going to thank Michael for his time and his enthusiasm and his help in putting this together and answering your questions today as well. We thank you all for joining us, and stay tuned for many more webinars and a lot of really cool resources that are going to be coming to the HCMA by the end of the year. So please do log on, become a member, and stay in touch with us. Thank you all, and have a great day.